morning, everyone. My name is Dana, and I'm with the University of Washington Prevention Training Center. Thank you for attending today's webinar on clinical syphilis diagnosis and treatment. This webinar is co-sponsored by the State of Alaska Department of Health and Social Services HIV STD program and us, the University of Washington STD Prevention Training Center. We will begin with a brief introduction to Alaska-specific syphilis epidemiology by Tracy Smith, the State of Alaska STD Program Coordinator. Next, Dr. Meena Ramchandani will present on the clinical diagnosis and treatment of syphilis. At the end of the presentation, our speakers will take questions via the chat box. Thank you, and here is Tracy. I'm going to unmute you, Tracy. There you go.
Thanks, Dana. Hello, everyone. As Dana said, my name is Tracy Smith, and I am the STD Program Coordinator for the State of Alaska HIV STD Program. In March of 2018, Alaska declared an outbreak of syphilis. Before I dive into the numbers, let's look at a few important highlights. The majority of the 2018 cases were among men, specifically men who have sex with men. It is important to note that not all men who have sex with men identify as gay. Many of our cases involved Alaskans who used mobile apps to meet their sex partners. Like meeting a sex partner at a bar, use of the venue itself is not a risk factor. The behavior at the venue brings about the risk. However, use of digital venues does often present challenges when it comes to notifying past sex partners of exposure to infection, which ultimately increases opportunities for disease progression and spread. Comorbidity with other STDs, such as chlamydia and gonorrhea, was common, and comorbidity with HIV was also an important factor. Sex with travel, both in and out of state, as well as drug use and history of incarceration, were also frequently reported risk factors. The State of Alaska HIV STD program provides partner services to individuals diagnosed with syphilis, meaning we attempt to elicit, locate, and refer all known sex partners for appropriate testing and treatment. Through this process, the original diagnosed patient's identity remains anonymous and disease intervention can be achieved. We are also a resource for clinicians, providing professional consultation and technical assistance for testing and treatment of syphilis. In 2018, Alaska had 96 total early syphilis case reports and 1 probable congenital case. For all of our remaining slides, the 1 congenital case is not included in any of the figures. This case met the CDC surveillance definition of a probable congenital syphilis case based on the mother receiving inadequate treatment in 2017. However, the infant was clinically diagnosed as not infected. Alaska's number of early syphilis cases in 2018 was the highest in over 40 years. And while we aren't talking about 2019 yet, I will take this opportunity to say that so far, our new reports have not decreased. As you can see, the highest percentage of cases has consistently been in the MSM population, and this trend is in line with those seen across the nation. For 2018, 74% of male cases were among self-reported MSM. That said, providers in Alaska should also be aware that a national trend of increased primary and secondary syphilis cases among heterosexual men and women who report methamphetamine, injection drug, and heroin use has been identified. And I expect this is a trend we could eventually see here in Alaska too. Early on in the 2018 outbreak, reported cases were largely in the white MSM population. As the year progressed, cases among the Alaska non-white population increased and showed a definite shift in the trend. For females, 2 of the 10 early cases reported were pregnant. Both were adequately treated, and in both cases, partner service efforts were successful in identifying and treating infected partners. The vast majority of early cases were diagnosed in the Anchorage-Mat-Su Valley Economic Region, with most of those being diagnosed in Anchorage. The 25 to 29 age group had the most reports overall, and these cases occurred steadily throughout the year. Case reports for those in the 45 to 54 age group occurred primarily in the early to mid part of the year, with a significant decline seen in the fourth quarter. 28% of early syphilis cases among men who have sex with men were either previously positive for HIV or newly diagnosed with HIV and syphilis together. The nature of certain syphilis symptoms increases a person's chance of acquiring HIV if they are exposed to that infection while syphilis is present. As I mentioned at the beginning, the State of Alaska HIV STD program provides partner services to individuals diagnosed with syphilis in an effort to intervene in disease transmission. 79% of 2018 syphilis partner investigations resulted in a favorable outcome. These are patients who tested non-reactive and were either preventively treated or not based on CDC recommendations, as well as those who tested reactive and were brought to treatment. 11% resulted in an unfavorable outcome. These were patients that we were unable to locate, as well as patients that were located and notified, but who refused services. The neutral outcomes reflect those patients who tested non-reactive but refused preventive treatment when it was recommended, as well as those records that were sent out of state for notification, those that were named back on a case but had already been treated, and those that simply did not fit neatly into any preferred surveillance category. The HIV program also played a key role in the identification and management of 3 early syphilis cases with ocular involvement. All of these cases experienced quite significant visual impairment prior to treatment. All were treated per the CDC treatment guidelines, and all patients reported experiencing improvements to vision within 3 or 4 days of starting treatment. Communication between HIV and STD program staff and medical providers was crucial to assuring proper diagnosis and treatment of these patients. Please don't hesitate to contact the HIV STD program with any questions at all regarding a suspected or laboratory confirmed case of syphilis, partner services and how that works, or syphilis testing and treatment. We are here to help. I've provided my email above, but as a quick important side note, please do not email any protected health information. State of Alaska email accounts are subject to public records request and thus are not confidential. Thank you very much for the opportunity to speak with you here today.
Okay, I'll get started. Hi everyone, my name's Mina. I think we're going to just get our slides up here. Tracy, thanks for giving a fantastic summary of the epidemiology and the local data. And thanks to everyone for being here to listen to this talk. So I'm going to get started. I have no disclosure, so I'm going to kind of go through these slides. I'm going to focus on main points that as a practitioner or public health person that you should know, but there are a lot of references on the slides for other data or more detailed information that you can then go back to the slides and use whenever you interact or encounter some of these patient scenarios again. So hopefully it'll be helpful. I'm going to start out with a little bit with the national epidemiology, signs and symptoms, staging of disease. Lab testing really confuses practitioners, and I think it's because there's just so many different tests and different algorithms. So hopefully we'll make it a little simple so that it'll be easy for you to encounter and interpret. And then treatment, complications, and then links to online learning courses. So this is really helpful for me to know what to emphasize on. And just to get a rough estimate for a feel for your practice, how many patients have you seen with syphilis in the last 1 to 2 months? And what I mean is a new diagnosis of syphilis. So this is helpful. I think the majority of people have not had a new diagnosis of syphilis, and that's really helpful. Okay, so can we get this polling down? Oh, I guess so that I can continue. And then this might be a moot point because most people have not seen a new diagnosis of syphilis, but for the 3 of you that have had a case of syphilis, how many neurosyphilis cases have you seen or been involved in taking care of? Okay, thank you. So this is helpful, thank you. So let's turn a little bit to the clinician's role in STD prevention. I'm not sure if you've had talks on this before, but really creating a welcoming environment helps your patients to talk about sex and their sexual history. And if you're honest with patients, they'll be honest with you. It's just really important to screen appropriately. Anatomic sites with recommended tests for, let's say, gonorrhea and chlamydia, really making sure the patients have appropriate vaccination status for maybe their sexual repertoire, and then prevention messages about condoms, HIV linkage to care and PrEP and pre-exposure prophylaxis. And the PTC has quite a few talks on some of these different kind of messages that it would be good if you haven't had this or you're not doing PrEP in your clinic to really learn to start to do PrEP and maybe hear one of the talks by the PTC on that. Because as Tracy pointed out, syphilis is really connected with HIV, both HIV patients, but HIV negative individuals who might acquire HIV in the near future. And then reporting cases to local authorities in terms of public health so that they can make sure that partners are managed and patients have been appropriately treated. And they can be a fantastic resource for you in your clinical environment. So aspects of the sexual history, asking patients if they have sex with men, women, or both men and women, or persons who don't identify with the binary genders, numbers of sex partners, how many men and women you have had sex with in the last 60 days, last year. I kind of get a feeling from my patient in terms of their sex partners, because for some patients it'll be 3 in the last year, but in some they can't even count in the last month. So I think that number kind of changes depending on how many people they have sex with. And then the sexual repertoire, both sex with men and women, and then condom use. I don't ask patients anymore about, do you use condoms? Because they'll say yes. I usually ask for a percentage. That helps me, 0 to 100%. Because if I ask patients, do you always use condoms? They say yes. And then when I ask for a percent, they're 70% of the time. So that kind of helps you in terms of your screening tests and making sure that you're doing a good STD screening. And then asking them about their sexual history and their STD history, and then checking in with public health, the public health clinic, because they'll have access to STD history and treatment in the past, even if patients have traveled from state to state. And then the HIV status of their partners is really helpful too, especially for men who have sex with men. So this is just a little epidemiology data for the nation, and syphilis is not only going up in Alaska, it's going up throughout the U.S. The light blue dotted line shows the rates of syphilis kind of going up in the U.S. from year to year, and you can see it's just going up. The male rate is skyrocketing, and it's been skyrocketing ever since the 2000s. The dark blue dotted line shows the male to female rate ratio, which is one way for the CDC to estimate the MSM population. So 88% of all primary and secondary syphilis cases, so early syphilis cases in the US in 2017 occurred in men. The majority of the male syphilis cases were in MSM. However, this last year, the cases increased by 25% in women. So as Tracy pointed out, not all men MSM identify as gay. They have sex with both men and women, and getting a really good sexual history from your patient is extremely important in terms of screening for their partners, especially women who are young and can potentially have a child. You want to be able to get them in and treat them as well. Congenital syphilis cases in the US have also gone up. The light blue bars are the congenital syphilis cases, and the dark black line is the primary and secondary syphilis rates in women, and of course both are going up. There are almost 1,000 cases of congenital syphilis in the US in 2017, resulting in 64 stillbirths. And I put the numbers of 2016 just to show how much it's going up. And so it's really important for all women who are pregnant to get syphilis testing at least once in their pregnancy. And, and some experts recommend, and the STD guidelines recommend, that a repeat RPR in the 3rd trimester and a delivery for those patients who are at high risk. So I would identify those patients who have more than one partner, non-monogamous partners, partners with substance use, the patient has substance use or homelessness, have been associated with syphilis. So then now let's turn to the disease. So syphilis is a chronic sexually transmitted disease. It's an infection caused by Treponema pallidum. It's a bacteria, and as you can see here in these pictures, it's a spirochete bacteria similar to Lyme disease. Infection is through small breaks in the skin or the mucous membranes, and it's highly transmissible, especially with early disease. So patients who have primary, secondary, or early latent disease, the transmission risk can be up to average 30% per sexual contact, so extremely high compared to other sexually transmitted diseases. There is rapid dissemination of syphilis via the lymphatics and the blood. The spirochetes enter through the site of contact. They develop a chancre at that area, and then they rapidly spread throughout the body to the CSF, the brain, the eye, the liver, the intestines, the kidneys. And why some patients develop symptoms in those particular organs and others don't has not yet been well determined. But I think it's important to know that syphilis does go throughout the body, and so that's why no matter what stage of the disease, you need to ask the patient if they have any symptoms of neuro, ocular, or otosyphilis, because the treatment's going to be different. So a brief refresher. And there's infection with T. pallidum. As I said, there's growth of organisms at site of infection and the dissemination through the various tissues. Primary syphilis is a chancre, and it is typically a painless ulcer, indurated border, very shallow at the site of infection, and patients will have regional lymphadenopathy. I will say clinically, though, I have been seeing a couple of patients with not that classic textbook case. They actually have painful chancres. And so just because you've been taught that it's a painless chancre, it doesn't mean that it's always the case. And some patients will have a secondary bacterial infection, so pus coming from the area. So if you see an ulcer, do think syphilis, especially in a patient that you've taken a good sexual history and they're high risk for that. The reason why it's often taught that the chancres are mostly painless, which is true, is that a lot of patients won't see it or feel it or recognize that it's there. And the chancre develops around 3 weeks after infection, spontaneously heals, and so patients might not have recognized that primary syphilis stage. These are some pictures we've taken in our STD clinic, and we've collected of a very classic primary chancre. As you can see here in the upper left, this is a very classic textbook case of a primary chancre, a little indurated, shallow, not very erythematous. The one on the upper right was mistaken for a herpes lesion. This is in the anal area. And then the one on the bottom, that looks like an aphthous ulcer, but this was a primary syphilis lesion. Clinically, you know, I think taking a good sexual history helps you in terms of distinguishing an aphthous ulcer from a syphilitic ulcer, especially in the mouth. Aphthous ulcers tend to be more painful, and patients won't have that classic regional lymphadenopathy. So that can help as well in terms of distinguishing the two. These are some other pictures of primary chancres. The one on the upper right is multiple lesions, multiple ulcers, which can be mistaken for a herpetic outbreak, and then outbreak of lesions. And then the bottom right is an ulcer that's huge and very mucousy or mucoid, and then has like kind of denuding of the skin. And in this setting, a lot of times I will see a secondary bacterial infection, so patients will have a lot of pain in that area. These are some atypical primary syphilis lesions. I'm showing these pictures because it's important to recognize this disease. The patient on the left has multiple ulcers throughout his genital area. The top right has like a fissure, and the bottom also is a fissure kind of lesion, and these can be painful too. This is one on the cervix, so just kind of thinking about when you're doing a pap smear, that these lesions can also enter kind of like the cervical canal and might not be as readily noticeable on the outer skin. So with typical primary syphilis, this is an important point. These tests that we do for syphilis, they're all serological antibody tests. And because they're antibody tests, people don't necessarily make an antibody right away. And so in about 15 to 25% of patients with primary syphilis, these non-treponema tests will actually be negative. So the chancres can occur anywhere. And if you see something that's concerning for a chancre, you test the patient for syphilis, because if it's positive, you can then take a look at their partners and get their partners into care. But you don't need definitive diagnosis to treat. If you think it's early syphilis, just go ahead and treat the patient, because the loss to follow-up and spread of infection can be extremely high. Now, secondary syphilis happens a few weeks later, on average of 1 to 6 weeks later, where patients get a disseminated rash and generalized lymphadenopathy. Some patients can have overlap. About 15% will have overlap where they have a chancre as well as secondary syphilis, but that tends to be more rare, but it can happen. These are very classic secondary syphilis lesions. The top left is very classic. We usually notice it on the palms and soles, but I will tell you clinically, I've had patients who have it just on their trunk or an isolated part of their body, and don't develop on their palms and soles until a few days later. It's important to look at the palms and soles because it can help you, and that's what we're always tested on as clinicians. However, if it's not on the palms and soles and the patient has a good history for high-risk sexual behavior, then do think syphilis and treat that patient before they walk out the door, because they are very infectious. This is a classic palms and soles lesions. This can be mistaken for working in the garden too much. You know, there are a little bit of scaling, but this is very classic for syphilis. Secondary syphilis can also present in some more rare forms, but with these syphilis outbreaks that we're seeing more of these rare forms, and that's why I want to show you some pictures. Condyloma lata are wart-like lesions. They're high number of treponemes. They can occur at any moist body site. Very contagious. Please wear gloves whenever you're evaluating these patients. But they're fleshy, they're flat-topped. They're very mucousy, and I think getting a good history from a patient in terms of how long they've been there can really help you in distinguishing HPV warts from syphilis warts in terms of their history. Mucus patches I've seen a couple of times. These also have high number of treponemes, so definitely want to do an entire good head-to-toe physical exam on any patient that you diagnose with syphilis, because they might not have that rash, and they might have these mucus patches, and they're highly infectious from these oral lesions. Alopecia is pretty rare, but I've seen it a couple of times and have actually made a diagnosis of syphilis just based on the clinical data of alopecia. It's an infection of the hair follicles. Patients get this patchy moth-eaten pattern. The loss of lateral eyebrows, to be honest, I've never actually seen or even looked for. I think that's hard, but I do have some younger patients who'll come to me and they'll say, hey, I was just at my hairstylist or getting my hair cut, and they notice I'm losing a lot of hair. And it won't be this typical male pattern baldness, but on the sides of the head, on the back of the head, they'll have this patchy kind of this alopecia. And definitely think about syphilis. Patients can get liver, kidney, spleen involvement, so they might have elevated LFTs, very classically associated with syphilis on board exams as an isolated ALK phos in a young MSM with high-risk behaviors. I have not seen this. A colleague of mine has seen Lewis maligna, which is necrotic skin lesions, as you can see here in the bottom photo. So let's put this in a little perspective. And your patient is a 37-year-old male to female who presents to your clinic for routine testing. She has no symptoms but has a positive RPR of 1 to 8 found on routine screening. Her confirmative TPPA is also reactive. She tests on occasion. Her last test was negative 2 years ago. So how would you clinically stage her disease? Primary syphilis, secondary, early latent, and late latent. And just go ahead, vote, even if you don't know, but we're going to go through the stages because I think this confuses a lot of practitioners. So I wonder if I could also, while we're doing this, yes, perfect. So this is the case. Great. I like this. Oh, wow. Okay. So no symptoms, positive syphilis testing. Last test was negative 2 years ago. Okay, great. So we can end the poll now, and I'll tell you that this is late latent syphilis, and we'll go through why. So latent syphilis. So latent syphilis is positive syphilis serology in the absence of clinical manifestations. So in that patient case, the patient did not have clinical manifestations, head-to-toe exam, no manifestations of syphilis, so they're latent. Early latent is infected less than 1 year. Late latent is infected greater than 1 year or unknown duration. So the patient case, the patient was last tested 2 years ago, so we would say that there's a late latent disease. And the reason it's important to make this distinction is because the treatment is different. So RPR titer 1 to 8, what does that mean? Why the TPPA? This is what confuses most practitioners, and hopefully will make it a little simpler for you. So serological testing for syphilis. You've got 2 different types of tests. You've got lots of different like antibody tests and all these different algorithms. I think it's confusing for people. But to make it easy, you have non-treponemal tests and you have your treponemal tests. The non-treponemal tests are quantitative. They go down with treatment, they go up with reinfection. Treponemal tests are good for screening if a patient's never had syphilis or they tell you they've never had syphilis. But once they're positive for life. Here at University of Washington, we use something, an EIA test. It's an antibody test. It's called syphilis IgG. That's what we use for screening. It's a treponemal test. Our lab, if that's positive, will reflexively do the RPR. The RPR and the VRL are quantitative. They give you a number, and it's a titer, which confuses a lot of people as well. But that titer you can compare to their previous history if they have one to see if they have actually a new diagnosis of syphilis. So I'm not sure exactly what you guys use in Alaska. Tracy, I'm not sure if you're on the call, but if you guys use the traditional or the non-traditional screening tests, the algorithms, but I'm going to go through both just to make sure. So the easy way of thinking about it is you need 2 positive tests to make a diagnosis of syphilis. So the traditional, and neither one is better than the other. The CDC advocates both. It's just about what public health labs have access to and what's cheaper and better for the patient population. So the traditional test is 2 serological tests. You screen with a non-treponemal test, that number, the titer, RPR or VDRL, and then you confirm with a treponemal specific test, a TPPA or the MHATP. And if both are positive, then you can just say the patient has syphilis, and you have to then look at those past RPR or VDRL titers to see if it's new or just kind of like a stable titer. It's like an old disease. If one is positive, the other is negative, syphilis is unlikely, but if you have a high-risk individual, I would probably retest them in 2 to 4 weeks to see if that TPP, if one of them becomes positive. And then if the RPR VDRL is negative, you can just say, no, the patient doesn't have evidence of syphilis. Now, that being said, remember, a lot of these tests are negative in primary disease. So if you have a patient who comes with primary symptoms, you test them, but you also treat them right then and there before they head out the door. The reverse sequence syphilis screening is what we use here in Washington State. This is when you screen with a treponemal specific test. And this is the one that's always positive for life. We do a syphilis IgG. If that's negative, you can say, okay, the patient has no disease, or it's a false negative in the setting of early disease, or basically it's an early disease. So if high clinical suspicion, I would repeat the test in a couple weeks. But if it's positive, our lab will reflexively do an RPR test. If that's positive, then we're done. 2 tests are positive. You can decide if the disease is old versus new. This is what stumps a lot of clinicians. One test is positive and the other is negative, and they're like, I don't know what to do. If one's positive and one's negative, you do a second treponemal test. It should be a different treponemal test. We do a TPPA. If that's positive, then you've got your 2 positive tests, and then you can decide if the disease is old or new. And if that's negative, that you can say the patient doesn't have syphilis. So this is just a picture to show what that RPR titer is, and it's just dilutions of the patient's serum. That's why there's a titer. And I went to our public health library. They were kind enough to show me Dr. Paul Swanson's lab, what they do. So they take these cards and they dilute out the patient's serum, and they mix the serum with charcoal antigen, and the highest titer or the highest clumping that you see with this charcoal antigen would be your titer. And it's just an eyeball test. It's someone who's physically looking at this. And that might be one of the reasons that in order to say that a patient has a new diagnosis of syphilis, you actually need a 4-fold increase in titer. So this stumps clinicians a lot, is that the patient's titer goes from a 1 to 2 to 1 to 4. In that setting, I would call public health and say, hey, has this patient had syphilis before? They say yes. What have their titers been historically? They can give you that number. And if the patient's kind of low risk, you can say, okay, just 1 to 4. They're high risk, I would retest, and maybe they're on their way up. But if they've always been in a 1 to 2, 1 to 4 area, in terms of their past titers, when you talk to public health, then you can just say, okay, that's kind of where they are. It's not evidence of new syphilis disease. I'm not going to go too much into this. This just shows you that the sensitivity of these serological tests for syphilis in primary, they're just not that great because they're antibody tests. Okay, so this case I like because it kind of hones in on a couple important points. 29-year-old pregnant woman seen for her first pregnancy visit. Her syphilis screening comes back with a reactive RPR 1 to 2 and a syphilis IgG that's positive. But she says, I was treated for secondary syphilis 2 years ago. You obtain records and see her initial titer was 1 to 256, But she stayed in care, and after treatment, the RPR fell to 1 to 16 at 6 months, and then 1 to 2 at 1 year, and remained at 1 to 2 2 years later. So she'd been regularly in care, and it's been in 1 to 2. So what's a compelling reason to treat her again? 1, her syphilis IgG is positive. 2, she's pregnant after an episode of syphilis. 3, the RPR is still reactive at 2 years post-treatment. And 4, she doesn't need treatment. So I'm going to go back so you can see the case. Hopefully that'll be helpful. Can they see the answer choices too on the poll? Yeah. Okay, great. This is nice. Basically on the poll, we are getting a complete distribution, which is why I like this question, because it hones in on several important points that I'll go through. Okay. So the answer is that she doesn't need treatment, and I'll go through why. So I will wait to go through why. There we go. Okay. So number 1, her syphilis IgG is positive, but she's had syphilis. Her IgG will always be positive. Number 2, she's pregnant after an episode of syphilis. Now this is key. Her syphilis was treated and well documented. You have evidence that she was treated, and the fact that she was in care and continued to have these low RPR titers. The RPR is still reactive at 2 years post-treatment. It reflects something called a serofast reaction, which I'll go into. And so therefore, she doesn't need treatment. We recently, well, actually it's not recent now. Time flies way too quickly. I think about a year ago, we had a patient who was positive with an RPR 1 to 16. Her last titer was done 2 years ago, and she was 1 to 256, something of the sort. But she hadn't been in care, and so I don't know if her RPR came down to 1 to 2 and is now back up to 1 to 16 versus the 1 to 16 demonstrates resolution of the disease from the 1 to 256. So for her, we actually ended up treating. But in this patient, you know, it's been well documented that she had come down in her RPR titers and remained at that 1 to 2. So you don't have to worry that she's on her way up. So a serofast reaction is persistent positivity of the RPR for years to lifelong at a steady state. You see this often with HIV positive patients, but also HIV negative in pregnancy. I have seen it now more and more. It does not mean a new infection. A new infection would be an increase in the RPR 4-fold. And remember, the syphilis IgG or the EIA test, these will always be positive. So that's why it's so important when you get a new syphilis, patient. Of course, you look for symptoms. If they have symptoms, you treat them. But you also talk to public health, because the public health records can tell you their history of RPR titers, and that can give you some more information, especially if patients travel and they're coming from out of state. Okay, let's turn to treatment. So for primary, secondary, early latent disease, you can treat at 2.4 million units benzathine long-acting penicillin intramuscularly ×1. Do not do other penicillin formulations. This MMWR report was the inadvertent use of basically the wrong type of bicillin to treat syphilis infection. You do not want an MMWR report about your clinic. So try to use the 2.4 million units of benzathine long-acting penicillin IM ×1. For allergies, and we do use this in our clinic quite a bit, especially when there was like a shortage of the long-acting benzathine, is doxy 100 milligrams BID for 14 days. Or if you hate your patients, tetracycline 500 QID ×14 days, because nobody is able to tolerate that medication. I've never given it. For pregnant women, you cannot use any other formulations but penicillin. So if they're allergic to penicillin, you desensitize them. That's the only option. And if patients are poor follow-up, you don't think they're going to take that doxy, you give them the shot. For late latent disease, you give 2.4 million units benzathine penicillin every week for 3 weeks. Okay, what's a Jarisch-Herxheimer reaction? Please tell your patients about this. It's an acute febrile reaction after the initiation of antibiotics for the treatment of spirochete infections. An easy, simple way to think about it is that the spirochetes are popping with the antibiotics. The body is basically seeing all these popped spirochete proteins and making a huge cytokine storm. And so patients will feel like crap. They'll feel fever, malaise, nausea. They can have exacerbation or worsening of the rash. It's usually in the setting of primary, secondary, most times secondary, because they have a very high burden of bacteria. It is within 24 hours, resolves within 24 hours, and telling patients they might experience this is very helpful. Tell them to take some Tylenol if they can. If they have throat swelling or shortness of breath, that's a different reaction, and that's when you're more concerned of a penicillin reaction and they need to go to the emergency room. But the fever and kind of like the rash worsening, that's very classic. Okay, I've already answered this question, but we'll just kind of go through it again. 47-year-old married man presents with a penile lesion of 4 weeks duration, generalized rash, sore throat, fever, headache, and malaise. Palmar and plantar lesions in addition to his rash, as well as oral mucus patches and generalized lymphadenopathy. The patient is just a walking syphilis time bomb. So you treat him with 2.4 million units of benzathine penicillin long-acting for secondary syphilis. He has no CNS symptoms at his visit. His RPR titer is 1 to 512 when he came in. His HIV test is negative. Very important. Please check an HIV test on every patient with syphilis who has not had an HIV test in the last 3 months. His follow-up blood test titer is 3 months post-treatment is 1 to 64. And you're like, what do I do? Well, would you treat him again with 1 dose of benzathine penicillin? Treat him with 3 weekly doses, perform a lumbar puncture, or do nothing? Okay, very good. I like this. So you would do nothing, because a drop in titer from 1 to 512 down to 1 to 64 is an appropriate decline. It's actually an 8-fold decline. A titer 4-fold decline is considered evidence of treatment. So that's fine. You just need to make sure the patient doesn't get reinfected. And so screening this patient every 3 months for all STDs would be recommended. So I'm not going to go too much into detail on this. This is very well described in the STD 2015 treatment guidelines. But a lot of clinicians get scared about the titers are not going down fast enough. But there are differences in terms of HIV positive and HIV negative. My personal opinion is that you should retest all patients with syphilis for all STDs at 3 months, not wait until 6 months. Because there's a high rate of reinfection. But you can wait. It takes about a lot of time before patients' titers tend to go down. And the guidelines are very good about distinguishing when you should really see serological 4-fold decline. If you have any questions about your specific patient scenario, please go on the PTC website, and there's a way that you can do a consultant question, and we are happy to get to you about it. But like I said, Public Health in Seattle, King County, we test our patients at 3 months because the risk of reinfection is high. All STIs we rescreen for, including HIV. Okay, this is very important. Contacts to syphilis. Now remember what I said. With early infection, patients might not have evidence of positive serological tests. So for patients who have primary, secondary, and early latent disease, you want to treat all their sex partners as early syphilis times 90 days, even if the serology is negative. The contact partner should be treated. Just go ahead and treat them with a dose of benzathine without waiting for the test results. Don't wait for serology, just treat. For those who are sex partners greater than 90 days, then you do the serology and treat if it's positive. Okay, so now we've gone down our little syphilis staging list, got to latent syphilis. Now, tertiary syphilis is when most practitioners are taught inaccurately in med school that neurosyphilis happens in tertiary syphilis. You're tested on the boards on like gammas and cardiovascular syphilis and aortic aneurysms and tabes dorsalis and general paresis and all the things. But that actually is very rare. Neurosyphilis can occur at any stage. And the reason why I want to hone in on this point is because no matter what stage, you have to ask your patients for neurosyphilis types of symptoms and signs. So it's invasion of the CNS by T. pallidum. Patients can get a reactive CSF VDRL or an increased protein or increased white blood count in the CSF. Untreated, it can lead to stroke. Ocular syphilis can lead to permanent blindness, and otosyphilis can lead to permanent hearing loss. So you have to ask all patients about ocular symptoms and signs. If they have ocular symptoms and signs, not only do they need an LP, but they need an urgent referral to ophthalmology, who should see them within a few days. And if they have otosyphilis and signs, they need to have an LP and a referral to ENT for a formal audiogram urgently. If they don't have ocular or otosyphilis signs and symptoms, but they complain of increasing headaches within a patient who's never had headaches, or gait instability, they're having difficulty walking, or any concerns for neurosyphilis, they need a lumbar puncture. So screening questions that we've found to be most useful are changes in vision. I find that when you ask patients blurry vision or floaters or spots that are new in relation to their syphilis diagnosis is very helpful. Changes in hearing, they usually complain of tinnitus or muffled hearing or hearing loss. That's concern for otosyphilis. And like getting that time course is really important because a lot of patients, my patients use a lot of meth, and meth can create some of these symptoms, but I think in time course and related to their syphilis diagnosis really, really helpful. And I think a lot of practitioners are not asking about hearing changes, and that's really important because ocular syphilis has been kind of at the forefront of, you know, it was in the MMWR report, and I think a big deal is made about ocular syphilis, but otosyphilis can happen as well. And just to note, a negative LP does not rule out ocular or otosyphilis. So if they have eye symptoms, they need an ophthalmology referral, not optometry. And if they have oto symptoms, ENT referral. They don't need both unless they have symptoms of both, but you still need the LP too. Okay, syphilis treatment, you can do aqueous. So if for neurosyphilis, including oto or ocular syphilis, they need IV penicillin for 10 to 14 days, or Procaine. Procaine is a shot that you can give with probenecid for 10 to 14 days. We use this a lot in our STD clinic. Unfortunately, for the past several years, Procaine was not available. However, it just came back on the market last week. So we've ordered a lot of this because it's very hard for us to get in a PICC line or, you know, admit our patient to the hospital for IV antibiotics, and Procaine works just as good. But you need to give the probenecid as well. Okay, I'm not going to go through too much of this, but for patients who don't have HIV, for neurosyphilis, the VDRL is very specific, but it's not very sensitive, and therefore the diagnosis is also made based on CSF pleocytosis or high protein. For HIV positive individuals who tend to have a lot of protein in their CSF anyways, you don't make the diagnosis based on the protein. You do make it off the CSF VDRL, but also pleocytosis, but there's a higher mark for the white blood cell count to be above 20 for the HIV positive individuals. So for neurosyphilis, not only do you want to treat them for neurosyphilis, but when they're in your clinic, treat them with that benzathine penicillin long acting right away, because that will treat whatever disease they have. It won't get into the CSF, but the loss to follow-up is high, and they can still transmit syphilis to other people in the community that they're sexually active with while you're arranging for the LFP and those referrals to the specialist. So in your clinic, treat them with the benzathine penicillin, and then doing, and right when you're kind of arranging for that workup for neurosyphilis treatment. But the benzathine penicillin doesn't get into the CSF. So if they do have evidence of neurosyphilis, you have to also treat them for neurosyphilis with IV or procaine penicillin. We kind of covered this. I'm not going to go too much in detail, but basically, syphilis in pregnancy is not treated with any other medication except for penicillin, and you treat for the appropriate stage of infection. You have to assess for neurological symptoms, and anybody who is pregnant, you want to reassess their titers at 28 to 32 weeks and at delivery. And if the mother's titer is reactive delivery, the infant titer must be checked. It's really important to do this because in order to diagnose a baby with congenital syphilis, you compare titers from infant to mom. And the 2015 treatment guidelines really delves very well into this and has a very nice, clear kind of guidelines in terms of diagnosing congenital syphilis in babies. But basically, congenital syphilis is really bad. It results in a lot of stillbirths and multi-organ failure. So kind of getting it to the end of my talk, these are just some resources. I'm not going to go too much into detail, but in terms of who to screen, for MSM populations in King County and Seattle, for those with higher risk, and you can see what we define as risk in the past year, we're screening every 3 months. And then those patients who are a little bit lower risk annually. We talked about pregnant women. All women should be at their first prenatal visit, and then high-risk women 3 times during their pregnancy. Homeless persons annually, and meth use and sex workers every 3 months. This is a very important point. All patients who have syphilis should be tested for HIV. And it's a nice way to kind of get a hold of both syphilis and HIV together, because those patients who have syphilis are at high risk of acquiring HIV based on, one, STDs tend to increase the risk of acquisition and transmission of HIV, but then also because of similar sexual networks. But then also it's a way to target and get all your HIV patients, or patients who haven't been screened for HIV screened. And if a patient is HIV positive, it's a way to link them to care if they're not in HIV care. And if they're negative, they really need to be counseled to start PrEP. In our STD clinic, one of the criteria, because we're very kind of, we only have certain resources, we do PrEP in our STD clinic. And those patients with syphilis, that's one of the criteria to start PrEP, because there is such a high risk of acquisition of HIV in someone with a recent history of syphilis. And this is just kind of going to show that certain STDs predict future risk of HIV risk among MSM specifically. There's a lot of data in the literature. Rectal infections, primary or secondary syphilis. So early syphilis and rectal gonorrhea and chlamydia do predict future HIV risk. So important to get those patients who are HIV negative on PrEP. And then this is just a summary approach for you if you want to go through it later in terms of the approach to syphilis and thinking about who needs therapy and what type of therapy. This is, if you start seeing more syphilis for your wall, it gives you the stage of syphilis, the criteria for staging, and the type of treatment. And these are some lovely resources. I'm not sure if you've heard some of these talks through the PTC, but our national STD curriculum, you just Google UW and STD or CDC STD curriculum. It's on the PTC site, but it's fantastic. It has all these wonderful bubbly pictures and very easy to go through. And kind of you can go through different subject matter from HPV to syphilis and goes through cases, the history. It's very well designed. So that's all I had. So let's take some questions. I think we have a few minutes for that, 5 minutes for questions. And if not, thanks for listening.
Did you answer the question about the
Just a reminder, if you have questions, put them in the chat box. And Tracy, I have you unmuted so you can answer as well.
So there's a question, I can read it. Thank you, it's a fantastic question. Is there something about the chemical makeup of methamphetamine as opposed to other substances that increases the risk of syphilis transmission? That's a phenomenal question. I don't know the answer to that. I do know that for our community, that's just based on epidemiology data in terms of we have high meth use and the risk of syphilis, the risk of, like there's certain drugs that make higher, lead to higher risk sexual behavior. And in our community, methamphetamine is one of them. Poppers are as well. And so both of those, I think sexual networks as well as high-risk behavior are associated epidemiology. I don't know in the literature in terms of chemical makeup. I can imagine that it might be different in other jurisdictions where patients tend to use more heroin or cocaine. That might be a different risk. So that's just more like the risk that we're seeing. Okay, well, thank you, everyone. Please feel free to use the PTC website for any questions that you might have, and appreciate you listening and for being here today. Take care.